After left forelimb lameness was abolished by palmar nerve blocks performed at the base of the proximal sesamoid bones, the horse exhibited a grade 4 out of 8 right forelimb lameness in straight lines. This horse shows an obvious grade 4 out of 8 right hind limb lameness, but it also has a mild head nod, reflecting a grade 2 out of 8 right forelimb lameness. The question is, are these lamenesses related? That is the right forelimb lameness compensatory for the right hind limb lameness, or are they independent? Are they related to both a right hind limb and a right forelimb problem? And I'm only going to be able to determine this by observing the horse under a variety of different circumstances and seeing the response to diagnostic anesthesia. On the lunge on the soft surface, we can observe a right hind limb toe drag and a shortened cranial phase of the step, a grade 5 out of 8 lameness. No forelimb lameness is seen. The horse looks out. On the right rein, there is a variable degree of right forelimb lameness, grade 3 or 4 out of 8. The horse looks out. The right hind limb crosses under the trunk during protraction. On the left rein, on a firm surface, the right hind limb lameness is accentuated compared with straight lines, grade 5 out of 8. On the right rein, the right forelimb lameness is now grade 5 out of 8. The right hind limb is crossed under the trunk as it is protracted, and the hindquarters swing outwards. We can see that the right forelimb lameness and the right hind limb lameness are varying independently of each other, and therefore we can say with some degree of certainty that there must be a concurrent, independent right hind and right forelimb lameness. So if we go back to the example I used before of the horse which had two sources of pain, using the 0 to 8 scale, we could say that the baseline lameness was grade 4 out of 8. After desensitization of the foot, the horse improved to grade 2 out of 8. There was no change after the low 4-point block, but lameness was abolished after the subcarpal blocks of the palmar-metacarpal nerves, so we now say it has a grade 0 lameness. And I obviously could also embellish that by some descriptions of how the horse was moving. Horses adapt in many different ways to lameness, depending on the source of pain, the severity of pain, the individual's response to pain, and the type of pathological abnormality causing the lameness. I believe we need a sufficient number of grades to cover a wide range of abnormalities. We often have horses with more than one source of pain causing lameness, and I think it's important to grade the improvement after diagnostic anesthesia under each circumstance in which we see the horse move. There are many clinicians that suggest that a 70% improvement is adequate for a single source of pain. I would tend to differ unless there is severe lameness, and we'll discuss more of this in the sections on diagnostic anesthesia.